Hey, welcome all my tooth doctors and doctresses. Welcome to another episode of The Tooth Factory. Today we're going to continue with pharmacology and learn about the adrenergic system. So hang on tight and get your papers out. Alright, let's get into the adrenergic system. We're going to talk about the Adreno Receptors, the adrenergic actions, the adrenergic drug classifications, and adrenergic blockers, which are anti-adrenergic drugs. So, fright and flight, guys. Race your heart. So, as before, let's overview the adrenergic system. Tyrosine turns into dopa. Dopa turns into dopamine, which then in the vesicles turns into norepinephrine production, and norepinephrine is then released into the synapses towards the adrenergic receptors, which are alpha 1, beta 1, beta 2, and then alpha 2. I'll get back to this discrepancy later. It can be hydrolyzed by COMT into an inactive metabolite. Norepinephrine will be reuptaken into the alpha 2 in the process. This is the adrenergic system. Let's talk about adreno receptors. Alpha 1, alpha 2, beta 1, beta 2. Alpha 1 is responsible for vasoconstriction, increase in peripheral resistance, increase in blood pressure, causes mydriasis, increases the closure of the internal sphincters of the bladder, so no urination. Alpha 2 is a little discrepant as it works opposite. Inhibition of norepinephrine release, inhibition of acetylcholine release, and inhibition of insulin release. Now this is for the feedback mechanism. It is when there is an oversaturation of norepinephrine and it needs to get back into its own house. Alpha 2 is stimulated. Beta 1, which is responsible for tachycardia, increased lipolysis, which means breaking of the lipids, increased myocardial contractility, so the SA node and the AV node in the heart are hyperactive, causing an increase in the stroke volume, and increased release of renin. All of these work in favor of the heart's production to be high. Therefore, cardiac output is high. It increases the blood pressure. It causes vasoconstriction. It causes increase in the heart rate. While beta 2, on the other hand, causes vasodilation. It also slightly decreases the peripheral resistance, slightly decreasing the blood pressure. Bronchodilation. The respiratory muscles are also dilated. Increased muscle and liver glycogenolysis. This means there is an increase in the sugar in the blood streams. There is an increase of glucagon, which is a stored form of glucose, and there is increase in uterine and smooth muscles relaxations. These beta 2 receptors will relax uterine smooth muscles as well. These are the adrenergic pharmacological actions. In the central nervous system, it causes excitation, causes alertness to be on the rise. At high doses, it may cause anxiety, apprehension, relentless restlessness, and tremors. In the cardiovascular system, it increases the force and the rate of contraction. The blood pressure increases, the peripheral resistance increases, and the heart activity overall increases. On the eye, it causes mydriasis. On the respiratory system, it relaxes the bronchial smooth muscles, causing bronchodilation. Metabolic effect is increase the glycogenolysis from beta receptor stimulation, therefore increase glucose in the bloodstream, causing hyperglycemia. So from these, we understand that they are opposite of the cholinergic drugs, which are parasympathetic drugs, and adrenergic are sympathetic drugs. Therefore, the uses are for vasoconstriction to increase the blood pressure and the cardiac arrest patients, bronchodilation during the treatment of asthma. In the central nervous system, it increases the attention deficit hyperactivity disorder to be cured. Adverse reactions of adrenergic pharmacology is anxiety, tremors, tachycardia, increased blood pressure, arrhythmias. Those are basically the hyperactivation of all the effects in pharmacology of the adrenergic drugs. These are opposite to cholinergic and similar to anticholinergic. Moving on to the adrenergic agonists. The adrenergic drugs are classified into direct acting, indirect acting, and mixed acting. Direct acting means stimulating the receptor sites. Indirect acting means enhancing the release of norepinephrine, and mixed acting will do both. So the direct acting include epinephrine, norepinephrine, isoproterenol, dopamine, dobutamine, phenylephrine, and clonidine as well. This will be an important drug to talk about. The rest of the drugs, the albuterol, pyrbuterol, salmeterol, formoterol, these drugs work on the respiratory system as bronchodilators, and they will affect beta 2. The indirect acting, amphetamine, methylphenidate, and cocaine, these are smart drugs. They will increase alertness, they will increase the attention span, and they will prevent the reuptake of epinephrine in the action to do so. So, amphetamine is used in narcolepsy, attention deficit disorders, and same goes with methylphenidate. Now, these are smart drugs. Cocaine, not such a good choice. Direct acting and indirect acting, mixed acting drugs, ephedrine and pseudoepinephrine. Ephedrine is direct alpha-1 agonist and enhances the release of norepinephrine. This causes nasal decongestion to be solved and also increases blood pressure by increasing vasoconstriction. Similarly, pseudoepinephrine does the same thing. Let's talk more about direct acting in the next slide. Recalling that I had drawn two dots here, the direct acting adrenergics will act here at the receptor by stimulating them. Epinephrine will act on alpha-1, alpha-2, beta-1, beta-2 in bronchospasms, glaucomas, anaphylactic shocks, and as a vasoconstrictor in local anesthetics. Anaphylactic shock is a condition in which epinephrine is a drug of choice. Norepinephrine will not stimulate beta-2, therefore it is primarily heart, vasoconstriction, hypotension, and shock are the three conditions that they are used for. Isoproterenol is a bronchodilator. Its effect on beta-1 is the same as effect on beta-2. So heart activity with this drug and lung activity with this drug is same. That is the uniqueness. Dopamine. It will act on alpha-1, alpha-2, beta-1, and beta-2 in conditions for congestive heart failure and shock. Dobutamine will act more on beta-1 than beta-2 for congestive heart failures. Phenylephrine is used for nasal decongestion, and it stimulates alpha-1 more than alpha-2. It is also used for pupil dilator. Clonidine, like I said, this was an important drug, stimulates alpha-2. Now here is alpha-2. It is back on the presynaptic membrane. When there is an excess of norepinephrine, it will directly stimulate alpha-2 in order to regulate the flow of norepinephrine. So these actions can be solved within range and do not produce any adverse effects like we saw in the earlier slides. Adrenergic blockers come into play when there is hyperactivity of the adrenergic receptors in their actions, as we saw earlier. Alpha blockers, beta blockers, and drugs affecting neurotransmitter uptake and release come into play. Alpha blockers are further divided into selective alpha blockers and non-selective alpha blockers. Non-selective will do both alpha-1 and alpha-2. Selective will further divide into alpha-1 antagonists and alpha-2 agonists. Alpha-1 antagonists such as doxazosine, prazosin, terazosin will work in conditions such as hypertension or urinary retention. When there is an hyperactivity of alpha-1 receptor, which is increased heart activity, it will work in hypertension and urinary retention to reduce that. Alpha-2 agonists. Remember, alpha-2 works opposite by inhibiting norepinephrine release. So in the blocker system, alpha-2 will be hyperactive, not blocked. Alpha-methyl dopa is the drug that does this, again for hypertension. Non-selective alpha blockers. Phenoxybenzamine, which is irreversible, and phentylamine, which is reversible. These two drugs will block both alpha-1 and alpha-2, and they are used for pheochromocytoma. The adverse effects of the alpha blockers are postural hypotension. Because it blocks hypertension, it can further take it down all the way down to hypotension. Reflex tachycardia. When there is hypotension, the sympathetic system kicks in and increases the heart rate to compensate. That will lead to tachycardia. Headache and dizziness, of course. Moving on to beta blockers, the non-selective alpha-1 and beta-1 blockers, first of all, are carvedilol and labetalol. They are used for congestive heart failure. They will block both alpha and beta. Just a side note. Now, focusing on beta blockers specifically, beta-1 blocker and non-selective beta-adrenergic blockers. Beta-1 blockers such as ace-butylol, atenolol, metoprolol. These lols are used for hypertension. Note one rule, AAM. All those olols that begin with A2M are beta-1 adrenergic blockers. All the other after M, such as propranolol, timolol, nadolol, these are mainly beta-2 blockers or non-selective beta-adrenergic blockers. Their activity is the same in hypertension, in angina pectoris, myocardial infarction, glaucoma, migraine. These are for propranolol. Timolol and nadolol for glaucoma and hypertension, and labetalol, which what we saw in non-selective, will help us with hypertension. So mainly it is the heart activity and the lung activity that is antagonized by adrenergic blockers.